Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Today, we're diving into the world of emerging infectious threats in rheumatology. We'll be exploring two infections that can mimic chronic rheumatic conditions: Chikungunya virus and syphilis, the great imitator. We've brought in two experts that will share their insights on diagnosing and managing patients with these complex infections. New behaviors, global travel, and climate change are reshaping the epidemiology of these diseases, and rheumatologists must be on high alert to diagnose these infections, which could be easily mistaken for more common rheumatic disorders. Dr. Kennedy Amaral is a rheumatologist and researcher in the Faculty of Medicine at the Federal University of Cariri in Brazil. He studies chronic Chikungunya arthritis, including its diagnosis and treatment. He has diagnosed and treated thousands of patients with chronic Chikungunya arthritis from one of the global epicenters of the epidemic in Brazil. Dr. Daniela DiMarco is an infectious disease physician and assistant professor of medicine at the University of Rochester Medical Center and provides care within the university's medical center, as well as the Monroe County Sexual Health Clinic. She completed her medical degree at SUNY Stony Brook, internal medicine residency at the University of Connecticut, ID fellowship at the University of Vermont, and she has a master's in public health from Dartmouth College. She focuses her work on sexually transmitted infections and serves on expert working groups at the local, regional, and national levels. Enjoy. Kennedy and Daniela, welcome to the show.
Thanks.
Thank you.
So let's talk first about chikungunya. And, I was reading the literature, and it seems that Brazil has become the major center of chikungunya outbreaks in the Americas. Kennedy, can you tell us a little bit about why it's so prevalent in Brazil? And then talk a little bit about how people with chikungunya present.
John, you are short. First, Brazil's climate is favorable to proliferation of Aedes mosquitoes. Furthermore, Brazil has not been successful at policy to combat the Aedes mosquito. For example, in 2024, this year alone, Brazil recorded more than 6.5 million cases of dengue fever and more than 5,000 confirmed deaths only this year in Brazil. And chikungunya fever, for example, is a devastating disease that has claimed millions of people worldwide. And Brazil is currently the epicenter of outbreaks in recent years. It's so impressive. I think this is so impressive to me that live here because since 2013, almost 4 million cases were reported with 50 countries or territories in Brazil of chikungunya fever. But between January and October 2024, no cases of chikungunya were reported in Europe, while in Brazil, almost 400,000 cases were reported this year alone. In the United States, for example, there where we live, only 15 cases have been reported. Only is a few number of cases about chikungunya fever. In Europe, whole Europe, no cases in this year. But in Brazil, for 100,000 cases is an impressive number.
So that means that the mosquito likes the heat and the samba music?
No, I think no.
It must be something about climate. And is there the Amazon forest? Is it because it sort of likes those climates?
And Brazil lives with Aedes mosquitoes along many years. And Aedes aegypti and Aedes albopictus live in Brazil with facilities, and the policies, government policies, is not successful in Brazil. Year after year, we have more and more cases of chikungunya and dengue in Brazil, year after year.
Wow. Tell me a little bit about how people with chikungunya present. What is chikungunya fever like? And how do you compare that to dengue?
Chikungunya fever is the most devastating disease I have seen in my life.
Wow.
Chikungunya fever is devastating disease. The patient have fever, high fever, polyarthritis, myalgia, headache, vomiting, nausea. But the patient with chronic chikungunya arthritis is more similar to rheumatoid arthritis. In the patient with chikungunya fever in the acute phase is more similar to a flare to rheumatoid arthritis. Do you understand me? Flare,
Yes, absolutely.
but more worse or
Wow.
worse. The chikungunya means to be controlled, and the patient walking controlled and can't to do your homework or your activities because the disease is very painful. Is the word is a disability disease.
Disabling. That sounds awful, by the way. And what percentage of patients with chikungunya fever actually develop a chronic arthritis?
Almost 40% of the patient with chikungunya fever developed chronic chikungunya arthritis. But is the real number is more than this because I see in my practice that a high number of patients with chikungunya fever, chikungunya virus infection, develop chronic chikungunya arthritis. About 50%.
Wow. And tell me a little bit about this arthritis. You mentioned before that the presentation of chikungunya fever sort of looks like a rheumatoid arthritis flare. How does the chronic chikungunya arthritis present? Does it look like a symmetric polyarthritis similar to rheumatoid arthritis?
Yes. The patient with chronic chikungunya arthritis or chikungunya fever in acute phase is similar to rheumatoid arthritis or flare of rheumatoid arthritis. But it's very difficult to difference this disease. But we have epidemiologic scenario or we live in an epidemiologic area and endemic area, and we have more facility to difference this disease. But a physician or a doctor or another health professional have more difficulty to differentiate because this disease is more similar, but it shows attention that chikungunya fever have a high fever and is an abrupt disease. The patient remember, I was eating or I was having lunch or was breakfasting and in the exact moment my joint have pain and the patient remember exactly the moment
Wow.
when he had chikungunya fever and is the patient don't forget this moment because it's a mark in your life. It's a mark in your
Amazing.
life.
So that's a great tip. So when a patient presents with a history of an acute fever and very acute onset of joint symptoms, certainly that's very unlike the typical presentation of rheumatoid arthritis, and it should make us think about things like chikungunya chronic arthritis. Chikungunya arthritis, does it affect the same joints that rheumatoid arthritis does?
Yes.
Okay, amazing. Because, we have a lot of patients in the US. Certainly, they probably don't get chikungunya from here, but we have a lot of immigrants or people that travel to Brazil and Central America, South America, that then come back and often report a history of fevers. So that's a very important thing to remember about, somebody that you're examining with arthritis is, asking a travel history and then asking a history of fever, and especially if the fever onset sort of coincided with the arthritis.
You are right. Is a topic very important about this disease because the endemic areas and the abrupt manifestation show attention to the doctor, and abruptly and the endemic area, and the patient is inside, the patient live or travel.
Okay. How do you diagnose chikungunya chronic arthritis? You need some serologies to be sure that they're positive.
In the acute phase, we use the serology, IgG and IgM, because it's more cheaper, is cheaper in Brazil, and the clinical manifestations, because in Brazil, chikungunya is endemic. And I see a patient with abrupt high fever, polyarthritis, and the cases are very common in the area. And father, mother, children, and parents in common have the disease. And it's more common. I see a man, a woman, child, and the grandmother, grandfather in my office with the same symptoms.
Amazing. That's another clue, right? Whether other people in the family have been struck with similar symptoms. And outside of the acute setting, like, when those patients come to the US and they have arthritis, to confirm the diagnosis, is it still helpful to check those antibodies?
Yes, is more usually we have IgG positive with these patients 3, 4, 5, 6 years after acute disease. We have IgG positive in these patients. Is more common.
Okay. Yeah. I've sent it a couple of times on some of my patients that, report a history of chikungunya or a febrile illness when they were usually, back home in Dominican Republic, Puerto Rico, Brazil. I think we could still send some of those testing. It goes to the CDC or some other place to get read, and it certainly takes a little bit. So once you make the diagnosis, how do you manage these patients with chikungunya chronic arthritis? What kind of medicines do you give them to try to alleviate some of their joint pain?
I think it's important to classify the patient according the disease that with symptoms. For example, many patients food criteria to rheumatoid arthritis, but lupus, scleroderma, ankylosing spondylitis, and fibromyalgia. And I sometimes treat this patient with duloxetine or methotrexate or biologics, depend of the classification that this patient have. And I have many patients with developed lupus with this four, but we need more clinical trials, randomized and blind longitudinal studies to understand more this question because there is no consensus about this treatment.
Hmm. Got it. So it sounds like in a patient that has chronic chikungunya arthritis and they look like they have sort of the manifestations of rheumatoid arthritis, you would treat them with the typical rheumatoid arthritis medications like methotrexate and biologics.
Lefonamide and
Leflunomide, yep.
sulfasalazine. Hydroxychloroquine is this
Hydroxychloroquine, yeah.
pronunciation, yes, is no more effective in chikungunya patients.
Got it.
No, it's no more effective.
Yeah. And, it was interesting to hear that you've had some patients that had chikungunya and then develop other rheumatic diseases like ankylosing spondylitis and lupus. How often have you seen that happen?
About 30 or 40%.
Wow. So it's still fairly common.
And severe forms of this disease, because I have 4 or 5
Yeah.
scleroderma patients after the chikungunya virus infection have with a severe form and fast progression of disease.
Wow. That's scary. Because, we always think that viruses or infections may be a trigger to autoimmunity, but it's very hard for us to actually identify sort of that initial infection. And it sounds like for chikungunya, it probably activates the immune system and then promotes autoimmunity for some reason.
John, I think chikungunya virus is a key to we understand etiopathogenesis of rheumatoid arthritis.
Huh.
I think about that.
That is super interesting. Yeah, it's so interesting that here you have a known pathogen, then the manifestations of rheumatoid arthritis. You're right, but better understanding that pathogenesis, it may give us a clue to what actually happens in rheumatoid arthritis, which may or may not be related to infections. There's certainly some data suggesting several bacteria that could be involved in the pathogenesis of rheumatoid arthritis. Great. Interesting. All right. Moving on a little bit to syphilis. Daniela, it sounds like syphilis, for better or for worse, it's making a resurgence over the recent years. How do you explain that? What's going on?
Yeah, thanks, John. Great question. So I think there's probably not one factor that can be attributed to the rise, but we've been seeing it, I would say, since the early 2000s, where in some areas of the country we saw almost no syphilis. It had really been sort of at the lowest it's ever been. And a lot of that was attributed to interventions associated with HIV prevention interventions. So, same idea, right? You're preventing STIs with the same strategies. It is thought that we are seeing general rise in STIs as we see wider implementation of PrEP. We do see less condom use, but that's really not the main contributing factor here. Over the last several years, we've seen an expansion of syphilis cases into people assigned female at birth. So we're seeing much more syphilis in that group. We're seeing associations with syphilis and substance use, particularly methamphetamine. And of course, we see that the substance use epidemic is surging. We have more cases of congenital syphilis as well. And that's just something you would expect as you see more cases of syphilis in folks with reproductive potential. So the factors associated with that go beyond those more easily to analyze ones, including things like associations with incarceration, with experiencing homelessness, and a lot of factors that are social determinants of health related to STIs as well.
Got it. I remember learning in medical school that syphilis was like the great imitator, right? It can sort of imitate many diseases, including rheumatic ones. Can you talk a little bit about how syphilis can present with musculoskeletal manifestations that a rheumatologist might see in their clinic?
Yeah, absolutely. And it really goes even beyond just the musculoskeletal manifestations when you think about those rheumatologic or autoimmune mimics. And there's this old adage from Sir William Osler, to know syphilis is to know medicine. And I paraphrase that a bit, but it's really true. It can do really anything. And so when you think about the musculoskeletal side of things, much like the viruses, chikungunya, dengue, Zika, it can cause polyarthralgias and polyarthritis after it disseminates. It can cause many different dermatologic manifestations, many different rashes, ulcers, at the local sites of infection. You can get ulcers in the genital area, but also the oral area. You can get ocular involvement, so uveitis. And it's relatively common that we get patients who are referred from ophthalmology who were being treated for idiopathic or what was thought to be autoimmune related uveitis,
Wow.
but was really ocular syphilis. And similarly, it can do anything in the eye. So you might see episcleritis or iritis or truly anything there. But you can also get solid organ involvement. So if you're evaluating somebody for nephritis, they might also have a rash. They might also have polyarthralgia, and you can see, how that's easily confused with something like systemic lupus, rheumatoid
Wow.
arthritis, and even various vasculitides. So lots of different clinical manifestations once the bacteria disseminates.
Yeah. I remember seeing once a patient, she was an elderly female patient. I don't remember what her chief complaint was, but we were called because we were concerned about giant cell arteritis. And she had these like very funny movements that were later described as, I guess, chorea or something. She turned out to have syphilis. So even mimicking like vasculitis, that's pretty crazy. Do you have an understanding of how disease happens? Is the spirochete actually invading the joints or the areas of involvement is in many cases, or is there a different pathogenesis?
I think it's a bit of both, and it depends sort of exactly what process you're looking at and what stage the person is in.
Mm-hmm.
So the way the infection works is you have contact with some sort of cutaneous or mucous membrane invasion of the bacteria, which is Treponema pallidum. And so from there, that's your primary stage. From there, the organism invades the soft tissues and then disseminates through the bloodstream or the lymphatics, but can really sort of go anywhere from that route. So it's not entirely clear, and I think there's a bit of debate about this, about when you're seeing these polyarthralgias, is it truly the organism itself in the joints, or is it the inflammatory response throughout the body that's recruiting that symptom? So I would say the jury is out on that, but there are ways where you can get direct bony involvement with the organism and direct joint involvement with the organism. And there have been cases where that's been shown to be present. Sometimes it's tertiary syphilis with gummatous disease, but sometimes it's something as simple as osteitis. And I actually think there was a report recently in the New England Journal of a case of secondary with osteitis with some nodular bony lesions on the forehead that resolved pretty quickly with treatment. I've seen that myself twice in clinical
Wow.
practice, where somebody's got a rash and they're actually in urgent care or emergency department for the rash, and they get sort of misdiagnosed with sinusitis perhaps, or some other unknown inflammatory condition, but ends up being secondary syphilis.
Can you talk a little bit about the stages? You mentioned sort of primary, secondary, and tertiary.
Yeah, primary is really that first stage after the infection occurs, where you have a painless ulcer or a chancre. And of course, the patients don't read textbooks, so you can definitely get atypical cases where you have multiple lesions or painful ulcers. Can look like herpes or other non-infectious ulcerative conditions. And that can occur anywhere at the site of inoculation. So it doesn't have to be the genital area. It can be the oral area or wherever on the body where that inoculation occurred. And after primary, if somebody remains untreated, they progress to secondary. So secondary is when, again, that bacteria has spread throughout the body, and you're really looking at multi-system involvement. So there can be generalized adenopathy, fever, rash, and other various mucocutaneous manifestations, alopecia. You can see the ocular symptoms. You can see different manifestations of neurosyphilis. You can have unilateral hearing loss, occasionally bilateral in more severe cases, meningitis or aseptic meningitis. That's when you would see that solid organ involvement like nephritis or hepatitis. If people were left untreated beyond that, you would progress into the latent stages. So early latent syphilis is that within that first year of infection. Late latent is sort of designated to just be beyond 1 year after the infection. And then tertiary syphilis, you've progressed on to some of those more advanced neurosyphilis manifestations. There are cardiac manifestations, gummatous disease, and things like that.
Talk more about that.
Yeah, these are kind of like soft tissue lesions with sort of necrotic center soft tissue lesions. They can mimic a tumor, I would say, and we don't see this as much, I think in part because there is such widespread antibiotic use in the United States at this point, and we just don't see this as much. But it can occur. You You can see these in the brain and the CNS, parenchymal tissues. You can see them on the skin occasionally. There can be cardiac gummatous disease. So any organ system can be affected by that. But I would say it's pretty rare, and we generally don't see that often in the US.
And does everybody with syphilis symptomatic?
No, and that's what makes it so difficult to diagnose is that it has these symptomatic stages, primary and secondary, but it has very long periods of latency. And generally, after that immune response from primary and secondary, when people enter latency, they can go for years with, as it's described, latent infection. And so that doesn't mean the bacteria is gone or the infection is eradicated. It's just not very active.
Do you know where the bacteria like to hang out?
Well, I'm not sure if I could tell you exactly. It varies depending on the person and the immune response and the immune function, I would say. But in those cases, you can see that evolution towards some of those perhaps more late findings of neurosyphilis, like meningovascular disease or something like that. You can also just see that folks who go years with untreated infection, who have literally no symptoms from that at all. And some folks can actually, from latency, cycle back to secondary syphilis, but that's usually from the early latent stage and not from those late latent stages.
Got it. Talk a little bit about diagnosing syphilis, because I remember, I think it was when I was primary care clinic as a resident, seeing patients and testing for syphilis, and you had to check the titers, and then you have to see were they treated before or not, because somebody that has been treated can still have positive titers. How does that work?
Very unfortunately, nothing has changed, and we're still using this very antiquated serologic method of diagnosis. So we have the treponema specific and the non-specific serologic testing. I think most people are familiar with the ELISA or other treponema specific antigen to get you an IgG or a total Ig level, which generally gives you a result of reactive or non-reactive. And then the other test that is most often used in the US is an RPR titer as your nonspecific treponemal test. And that gives you a quantitative result. So you get not only the reactive or non-reactive, but also a titer you can use to monitor for successful treatment afterwards. In other countries, some use a VDRL titer instead, and we use that in the US on CSF, and that's perfectly reasonable as well. But it's generally recommended to pair the tests when you're trying to make a diagnosis because, as you can imagine, in rheumatology and ID, when we're looking at these, there's a lot of cross-reactivity with other conditions, other infections, other things that have nothing to do with syphilis. So it can be a diagnostic challenge when you're trying to work with these.
Okay, so you recommend checking for both, for VDRL and RPR?
Yeah, well, generally you'd like to have one treponemal specific test and one non-specific test. And most labs have moved to an algorithm where you can do that automatically. So you'll just order a syphilis screening test and they'll reflex to the other to either confirm or evaluate further that positive test if the first one's positive. There is still the situation in some labs where you can just order one test at a time. So you might just be able to order the RPR and that's fine too. Just kind of knowing the limitations of the tests that are out there is important when you're trying to do accurate screening.
Yeah. I'm thinking now, so, when we have a patient with an autoimmune disease, rheumatoid arthritis or something, we often check for chronic infections. And the typical infections that we check are hepatitis B and C and TB. And mainly because we're often immunosuppressing the patients and we think that we should know about those chronic illnesses, which may get worse with treatment. I wonder what your thoughts are about, should we be checking for syphilis as well? Not only because, the disease might get worse if you immunosuppress them, but because syphilis may actually be the disease.
Yeah, absolutely. I would advocate for that. There are definitely some very specific screening recommendations for syphilis that CDC has outlined. But I think whenever you're thinking about these other things, particularly, if you're going to test somebody for HIV, for other STIs, the STIs travel together. And so it's a natural part of that. And it is one of those infections that, as you said earlier, mimics rheumatologic disease. And I think testing for that, it's a really nice place for that. It's a really nice indication. It helps to have a conversation about sexual history and sexual activity, but you might find folks who have, as you said, infections years ago that just didn't get treated. One common mistake that we talked earlier about testing, if you have two positive tests, so maybe you have a positive treponema pallidum IgG and you also have a positive TPPA, but your RPR is non-reactive, that doesn't mean a person does not have syphilis. And that doesn't necessarily mean that they got treated years ago. So if they can't remember being treated and it's not on record with the health department, they, probably have late latent syphilis. The RPR drops over time, just like other titers, especially when you're years into late latent disease. So you can have a negative RPR titer and still require treatment for syphilis.
Got it. Now, I'm just wondering also, what about the costs of testing? Are those expensive tests or?
Testing is generally pretty cheap and, diagnostically is covered by insurance if you have the appropriate indication, which you would when you're evaluating these different conditions. And screening would be covered for those who, if you meet U.S. Preventive Task Force, recommendations or CDC recommendations, screening should also be covered by insurance as well. But the testing is usually pretty cheap. And they're point of care tests now that give you at least just a total antibody, reactive or non-reactive. They don't give you a lot of other information, but if somebody's never been treated or evaluated, it can be helpful in that situation.
So who does the CDC recommend to be screened for syphilis?
Yeah, so a lot of different groups. CDC recommends screening for pregnant folks, screening for cis women, and cis men, depending on a few different factors. So men who have sex with other men, routine and regular screening is recommended. For transgender and gender diverse folks, likewise, routine screening. Folks with HIV also have their own screening recommendations. And then, for folks who don't fall into those categories, screening sometimes depends on personal factors and activities, things like substance use, incarceration history, number of sexual partners, things like that.
Okay. So talk to me about treatment. Is it still penicillin?
Treatment is very easy. It's penicillin. It's still penicillin. It gets a little more complicated if you have central nervous system involvement. So that needs 2 weeks of intravenous penicillin, which often requires a PICC line. But generally speaking, it's 1 to 3 doses of intramuscular penicillin. And the penicillin shortage that we were in recently has improved. It's the long-acting form of penicillin. It's not the short-acting form. So it is important that you're looking for that benzathine penicillin when you're starting treatment for syphilis.
And as you mentioned with the titers that they may go down, should you check titers or should you monitor for treatment success after treating patients with penicillin?
Absolutely. So after treatment, for folks who do not have HIV, you're going to repeat that RPR 6 months later. And the frequency of how often you do that and for how long you do that depends on the stage and also depends on a person's HIV status. For folks with HIV, you do check it a bit more frequently just to make sure treatment was successful. You're looking for that titer to come down with a 4-fold decline.
4-fold decline. Okay. And what's the long-term outlook of patients who had either any of the manifestations that you mentioned, whether it was arthritis or uveitis or anything else, after receiving penicillin?
Yeah, I think in general, I would say it's pretty favorable, particularly with some of the musculoskeletal things. What we do notice, particularly with the central nervous system manifestations, there's often quite a lag time between symptom onset and diagnosis. It can be several months before syphilis testing is sent and the diagnosis is made and treatment is delivered. So it does seem that the longer you go without appropriate treatment because of the bacteria or the immune response or the combination of the two, there can be a component of irreversible damage, particularly within the central nervous system. So those are cases where you might see some more long-term sequelae.
Got it. Great. Syphilis. Who knew? Kennedy, let's bring you back into the mix. And now, these are sort of questions or discussions for both of you. As a rheumatologist, where we're seeing patients with a variety of different conditions, when should we think about infections possibly causing the symptoms that we're seeing in clinic? what are some red flags that should make us think about chikungunya, syphilis, or other infections?
It's very important to think about the initial symptoms and the form how the symptoms starts. In chikungunya fever, how I said, the symptoms is very abrupt and is not common in rheumatic disease. The symptoms starts very fast, abrupt, an abrupt way, and is more common in rheumatic disease that the symptoms are more slow is more have a great duration, and chikungunya fever is more abrupt. And the principal is the main aspect of chikungunya fever. And other aspect is the severe form, because it's very important to remember that chikungunya fever is not similar to dengue, is not similar to Zika virus, because chikungunya is very disability.
Okay. Daniela, what about syphilis? Kennedy talked about the acuity of presentation. Does that also happen with syphilis, or is it more sort of indolent as many rheumatic diseases are?
It can be either way, and a lot of it depends on the person's threshold for sort of seeking healthcare, because a lot of people are out there hanging out with some of these symptoms and just tolerating it and going about their day. And for some people, they just feel a lot worse and go in. But I would say it's depending on the person, it's usually more indolent. But some people get those fevers and, flu-like symptoms, and they just come right in. I think, for us, in ID, we see a lot of the more challenging cases. And so one that pops out in my mind is just a person who had lupus and was being managed as a lupus flare, but in the end actually had secondary syphilis and was having all the same classic symptoms as the lupus flare, was being managed accordingly by her rheumatologist, but not improving. And so, that was, I think, a highlight of, as you mentioned, just what are the keys and not to miss. And I think it's maybe having a conversation each time you see folks about the potential for STI acquisition, if that's a possibility, with their primary care doctor or any provider they're seeing regularly who can assess that sort of thing, so that screening is happening and hopefully these things are picked up before they progress to that point. But folks with and without, rheumatologic conditions can get syphilis and have very similar manifestations to other conditions.
Got it. And Daniela, in your experience, are patients pretty forthcoming about their sexual history so that you can rely on that to sort of gauge their risk for syphilis? Or should we just test everybody?
Yeah, it depends on that patient-provider relationship, right? That trust. And it also depends on how the provider asks the questions. So, of course, folks who are used to it and more experienced with it have that language and conversation starters in their mind. And if you build it in and normalize it into the routine, it becomes a lot easier to do.
It sounds like you may have some tips for us, Daniela.
Tips. Yeah, I think, asking open-ended questions, asking folks things in a way that allow them to answer and not kind of directing the response in a way, but also just, as I said, normalizing it. So you're asking everybody the same questions and you're not really picking certain people where you're going to ask or not ask. And you'll be surprised by some of the answers that you get. And sometimes folks aren't ready to have that trust, but the more you do it, the more they trust and want to share. But there are situations in which syphilis testing is truly appropriate for folks in a broad scale, and that might be their local epidemiology or their personal activity or behavior factors. So again, if you standardize it as part of your assessment, and it can just be one question, any sex partners or any partners since I last saw you, something like that can be a good starting point.
And then I also wonder about serologies, like autoimmune serologies. So for instance, if a patient has rheumatoid factor and CCP positive rheumatoid arthritis, is that less concerning for chikungunya than a patient that would be seronegative? Similar for syphilis, I would expect syphilis arthritis to maybe be seronegative. I don't know if you guys have any thoughts or evidence behind those assumptions.
Yeah, for syphilis, their serologic testing should be positive.
You're right, for the syphilis bacteria. But I'm wondering, like that patient with lupus, did they have lupus serologies? Or should we, right? Like, does that make it less likely that they actually have syphilis? Or, if they have rheumatoid factor and a CCP positive, should we think about syphilis less?
We see syphilis antibodies triggered by a lot of different things, including some of these more modern, very immunogenic vaccines. And we do see that people have antibodies to other conditions or even other infections that can be present when they're acutely diagnosed with disseminated syphilis, then are actually not present once they're treated and you're a few months down the road. So that might be a situation where you treat the syphilis and circle back to repeating the serologies a few months later.
Kennedy, what's your experience with chikungunya? Like, are those patients that presenting like rheumatoid arthritis, are they going to have a rheumatoid factor or a CCP?
Since the patient have symptoms similar to rheumatoid arthritis, I treat this patient with as such rheumatoid arthritis. It's similar to rheumatoid arthritis. Many patients with rheumatoid arthritis don't have CCP and rheumatoid factor positive. So I managed this patient this for. The patient have similar symptoms and VHS, ASR, SR, and PCR
BSR and
uh,
CRP. Yep.
and CRP elevated or heights. I treat with rheumatoid arthritis. It's similar to a rheumatoid arthritis, negative.
Okay. So just to clarify, the patients with chikungunya that look like rheumatoid arthritis, most of them are seronegative?
Yes.
Got it. Okay. So I guess that's another clue, right? That may be useful to diagnose chikungunya in a patient, with a history of this acute arthritis who you see in clinic. They look like rheumatoid arthritis, but they're serologically negative for RF and CCP. You may think more that chikungunya may be more likely in those
But
cases.
John and Danielle and everybody, this is my practice. I have been almost 2,000 patients with chronic chikungunya arthritis in my office, only in my office and alone,
Wow.
and 2,000 patients with chronic chikungunya arthritis. And this is my practice. There is no a consensus into rheumatologists around the world because Brazil is the epicenter of chikungunya fever, but there are no studies, many studies about this topic. Unfortunately, there are no studies about this topic.
Got it. No, that's fascinating. And it's incredible the experience that you've had with these patients. So that I guess you're going to be my contact person if I ever diagnose chikungunya chronic arthritis in a
All
patient.
right.
I'll be giving
All
you a
right.
call. So, and you also use biologics in these patients, and are biologics just as effective as they are for rheumatoid arthritis?
Yes, I have many patients using biological therapy. Many patients include because it's a very similar form to rheumatoid arthritis.
Okay,
It's a
fascinating.
severe,
Yeah.
it's a severe form.
Yeah. So one of the things you mentioned is that there aren't any consensus guidelines for the management of chronic chikungunya arthritis, which is something that certainly needs to be done. So Kennedy and Daniela, any other things that you think are sort of the missing pieces of the puzzle? Any other research that should be done so that we better understand, chikungunya or syphilis?
Syphilis, I think there's a lot left to learn, even though it's been around many, many years. And I think this connection, as you mentioned, between other conditions is really important. But it's not syphilis alone. It's a lot of these different infectious diseases where we're seeing more and more, and probably more so with these infections acquired as we see more climate change. We're seeing more vector-borne illnesses. So, of course, with chikungunya, as Kennedy has described, it's super important that we get better diagnostics, but the same is true for syphilis. We need better diagnostics. We need ways to more accurately say if somebody has current active infection that's causing the issues that they're coming to you with, so you can really deliver the best treatment. It's great that penicillin is accessible and we can provide it so easily, but if their condition is truly lupus or rheumatoid arthritis or any other condition, wouldn't it be great if we could more promptly start treatment for that? So I think for me, one of the most important things, and then probably the second thing after diagnostics, is understanding the interconnectedness with the immune mediated manifestations a bit better. And are these sequelae that we're seeing pathogen mediated directly? Are they sort of secondary immune mediated? And what's the best way to manage those? I think, as Kennedy very well described, that's not well studied.
So I wonder, with climate change and the world becoming warmer, how that's going to change the epidemiology of chikungunya, if it's going to become more prevalent in the US.
But it's very interesting because other countries have a similar climate with Brazil, and several regions in Brazil is different the number of cases of chikungunya and dengue. In nearby cities, I live in Juazeiro do Norte, and I work and live in the epicenter in Brazil of chikungunya cases. Brazil is the epicenter in America, and I live in the state with is the epicenter in Brazil, and I live in the city that is the epicenter in my state.
Oh my
And I
goodness.
live and work in three cities: Araripina, Juazeiro do Norte, and Salgueiro. And these cities are in the top 10 city highest of chikungunya cases in Brazil in 2000 and 2022. And is impressionant is because the city is nearby and the number of cases different. They have the same climate. And I think that policies, government policies, is more effective in a city and other city no.
Got it. That's super interesting. And Daniela, I was just thinking, penicillin, why hasn't syphilis become resistant to penicillin? Penicillin's been around since forever.
It's interesting as we think a lot about using biomedical preventive strategies for STIs. Some of you may have heard about doxypep or using doxycycline to prevent bacterial STIs. Resistance among STIs is a concern, and so far it hasn't been seen for syphilis with penicillin, for doxycycline. There was a period where azithromycin was used, and resistance did seem to emerge, or at least reduced treatment efficacy emerged with that. But so far, we haven't seen that with penicillin, and I can't tell you exactly why.
That's very good. Kennedy, one last question. If I were to want to go to Brazil on vacation, what can I do to prevent chikungunya infection in me?
This year, the FDA approved the first vaccine against chikungunya virus. And if you can, you get a take vaccine. But in Brazil, it's very important to use long
Long sleeves?
sleeves and repellents
Repellent, yeah?
repellents and close the doors and windows. And the people in Brazil have to importance to combat the mosquito vector, the Aedes aegypti. The Aedes aegypti is the main vector to with chikungunya fever. And if you travel to Brazil, take care. Take care and protect you and your family because chikungunya have been surfing in many people in Brazil.
Yeah, yeah. I still want to go and visit, Kennedy. But Kennedy, Daniela, thank you so much for your time. This has been really eye-opening, and it really sort of brings to light how important, thinking about these infections are in people that have musculoskeletal manifestations and other manifestations that we see in rheumatology clinics. So I really appreciate your time and your thoughts, and thank you for coming on the show.
Thanks for having us.
Thank you, John. Thank you, Danielle. Thank you, everybody.
What a fascinating discussion of how infectious diseases can mimic or provoke many of the diseases that we care for in rheumatology. Doctors Amaral and DiMarco really underscored the importance of a thorough patient history, including a travel and sexual history, to avoid missing these great imitators in practice. It just shows how a patient's clinical story and geographic context can be just as critical as any laboratory test in steering us towards the correct diagnosis. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find all of our show notes for this and other episodes at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, don't forget about these infections. And of course, stay healthy.